Welcome to episode number 7 already. So lucky number 7 of Coronavirus Conversations. And my name is Adam Hertzberger, and with me is Dr. Josh Williamson. And so we've gotten a couple email questions and comments. So I think we'll kind of start with those to kickstart this particular episode. And the first one, so we received an email from Megan. So I'm just going to read this real quick. So, hi, my name is Megan, and I'll be a sophomore this coming fall. Thank you for listening. Thank you for writing in. I tuned into your videos regarding COVID-19, wanted to ask, would a COVID positive patient who was breathing fast and tiring quickly prior to ventilation, would putting that patient on BiPAP or having intubating the patient, would ECMO ventilation be the better choice for survival? The reason for my question is when you talk about the rate of respirations to lung compliance and patients tiring from breathing at a fast rate under pressure, would ECMO oxygenate the lungs more efficiently and help stop the rate of COVID spores from spreading and replicating? Okay, so that's a very good question, very, very detailed question. So Josh, as the resident medical expert, so what do you think?
It is a good question, and it's one of those things that kind of makes you think back and say, no, wait a second, where does that question come from? But she's right. It would make good sense that if you were able to bypass the lungs, you avoid the area that's causing the problem, and things get better. The problem is the same as it is with a lot of things. In theory, it seems like a good idea, but in practice, it becomes fraught with problems. And that's the thing. ECMO has a lot of complications. As you can imagine, you're taking blood from a large blood vessel, usually from a vein, and you're taking it through a bunch of tubing into a machine, oxygenating that blood, and then putting it back into the circulation. So anytime you're taking blood out and putting blood back in, you run high risk of infections. Of course, hospitals are always trying to avoid that complication, but it's a serious one.
Mm-hmm.
And then we touched on the fact that COVID patients are having coagulopathy issues. So their blood is coagulating too much, and they're on blood thinners, and you have to be on blood thinners for ECMO too to make sure that blood doesn't coagulate during the process. So you have, and that's a treatment that has complications as well. So you're kind of tacking on complication after complication after complication when it comes to ECMO. So it's a very invasive procedure. And unfortunately, a lot of patients don't survive ECMO.
So Josh, can you just give a brief, just for the general listening audience here, what is ECMO and
yeah.
what is it used? Yeah.
Yeah, sorry, that would be,
No,
good
that's
for
fine.
find it. So extracorporeal membrane oxygenation. So extracorporeal, it's out of the body, and they use a membrane to oxygenate in this machine. So you're basically taking blood out, running it out to a membrane where the membrane does the exchange instead of your lung membranes doing the exchange, and then it brings it back in.
Okay.
So it's a bypass machine. So patients that are having heart surgeries, they go on bypass. So that's a term that people hear, and it's the same process. You're just basically taking blood and bypassing it around whatever organ you're trying to work on or trying to help. So this is a lung bypass machine, basically.
Okay.
It's used for a lot of different things. In pediatrics, it's used because for conditions where babies' lungs aren't fully developed, or if babies' lungs are not working properly, then that's a kind of a last resort to allow those lungs to start to develop. ECMO is typically a process. So patients go on a course of ECMO. It's usually between 3 to 10 days, I think, is what most protocols work under. I'm not sure what the COVID protocols are because this is only done in specialized centers. In the Pennsylvania Department of Health website, you can actually see how many patients are on ECMO each day. Um, I didn't. I'll actually be checking that later today. I didn't see the numbers for today, but we were at 20 patients last week, and we've been kind of in the teens to 20 range during the course of this pandemic so far, and that number's been coming down a little bit. So as we get less hospitalized patients,
Hmm.
less patients on ventilators, less patients on ECMO.
And so, just to kind of wrap up her question, so I guess the idea is would this ECMO procedure, allowing for this oxygenation potentially, would that help stop the rate of virus replication, right? And so, what do you think?
Right. So again, this is a supportive treatment. This is just like all- just like the ventilator is, just like extra oxygen. You're just supporting the patient while the patient's body is actually fighting the infection on its own. Hopefully, with the help of medications. That's something we've talked a lot about. Are these different medications to try to help slow the virus? And we're waiting to see how effective those treatments are going to be. But ultimately, when it comes to a viral infection, we usually just try to allow the body to work and try to make sure that patients stay hydrated and their oxygen levels remain at a good number, over 92% typically.
Right. And I've read that with some COVID patients, that number comes down quite low, right? I mean, I've seen 40s, 50s, 60s, so really really low oxygen levels. There's even an article, I think they call them happy hypoxics or something, that some doctors are referring to. I mean, these patients come in. I mean, they have a slightly accelerated respiratory rate, but otherwise seem fine, and their blood oxygen levels are like 50 or something, which is pretty wild. I mean, you would think those patients would be bedridden. but, um,
Right, and it's always interesting when a condition they talk about blueness in the around the mouth and on the
mhm,
face.
mhm,
If you're turning blue, that's not a good sign. But usually, if you're turning blue, you have other symptoms. That you're sick, and then these patients know they're sick also. Don't get me wrong, but you're right. For their level, you'd expect them to be even more sick than what they're showing, than what they're presenting
yeah.
in the early stages.
And is that usually, Josh, the case where there's sort of like maybe fluid buildup or something in the lung, that you're not getting the oxygen passing across the air sacs in the lung to the bloodstream? Is that usually the cause of that?
Usually, the cause, I think, is the right way to say, because common things um, are typically what you're looking for, but you have to have a lot of lung volume affected with a pneumonia or some other lung process for your oxygen levels to go down.
Okay.
So you can have you can function very well with a good percentage of your lung not working at full capacity. We have a lot of reserve in our lung,
Hmm.
typically, for most healthy people. Um, but then there are some other conditions where the oxygen carrying capacity is affected, and so those are some of the conditions where you see these lower levels. So I have I have not seen much to address that issue. How deeply affected our bloodstream's oxygen carrying capacity is with this.
Okay.
There's a condition called methemoglobinemia, which is very rare, but those patients are blue, um, but they look good, and
Mhm.
so that description that you had just reminds me of that condition, and that there's nothing wrong with those patients' lungs. It's the oxygen carrying capacity that's affected in that condition.
Right. Okay. Well, great. Yeah, Megan, thanks for writing in. So just to kind of wrap it up from sort of a from my perspective as a biologist, I would say that allowing somebody to um, survive longer, and that's the goal of ECMO, is my understanding. It's just basically it's a, supportive care. It's a survival mechanism to allow time for the body to potentially fight off the virus. So that particular intervention, like ventilation, ECMO, all these breathing things that help assist breathing and oxygenation, those aren't going to um, affect virus replication itself, right? That's not an antiviral intervention. It's a life supporting intervention, is my understanding. So
Right.
great. Well, thank you, Megan. Okay, so next up, we just kind of do a little bit of a roundtable here of some things. So the next, this is more of a comment. So so I got an email yesterday from our acting president and provost, Karen Campbell, and this is really interesting. So she is referred to affectionately once in a while as the Bat Lady because in her life as a biologist, she has studied bats, and so she, so very cool. And so she sent me a notification here so this is basically a press release, excuse me, and this comes from the Department of Conservation and Natural Resources. And the headline is Caves in Forbes State Forest Remaining Closed Due to COVID-19. And so there are 3 caves within Forbes State Forest, and they're closed until further notice due to COVID-19. So closed off to, basically researchers, the public, etc. And so the reason that she sent this to me, it's really interesting, is the the underlying idea, or the rationale behind this, as far as I could tell, is since this virus came from a bat somewhere in China and then made either a jump directly to a human, or more likely probably went into an intermediate animal and then made the jump into humans. The thought process is that they're trying to basically prevent a human from giving the SARS-CoV-2 virus to a Pennsylvania bat and potentially creating a new reservoir of infection here in the United States. Now, this is a question, it's a very interesting one. I would classify this under the headline, an extreme abundance of caution, right? It is, I suppose, theoretically possible that we could give a bat COVID-19, and then because they're in these, in these hibernacula where they're, in very close contact, it's, infectious agents can spread very easily among bat colonies, and so that's what they're trying to prevent from happening. Now, one thing I don't know, and I don't know if anybody knows this, I could, try to research this a little bit between now and the next episode, but it's thought that at least SARS-1, and I'm not sure about SARS-CoV-2, came from a horseshoe bat originally. Now, I did ask Karen by email, and she said that there's no horseshoe bat species in this area. And so I'm not sure how easily SARS-CoV-2 jumps across different species of bats, but let's say hypothetically that they could infect like a brown bat here in Pennsylvania, right? So the the government's perspective, they're trying to prevent the creation of a new reservoir of infected bats here in the United States. So once again, in theory, I guess possible, but in practice, in reality, I'm not sure if those bats are even infectable by SARS-CoV-2. That would have to be work that would have to be done by researchers or through surveillance mechanisms. So anyway, just sort of an interesting thing that was sent our way.
It is very interesting. And we talked a little bit about animals and pets previously.
Yeah.
But
So
I
cats.
agree that if a person is deep in a close cave and it's hard work to climb into those areas. From what I understand, Dr. Campbell would know better than I would.
Right.
Uh, but you're exercising, you're breathing heavy, you're spewing a lot of viral particles out if you're an asymptomatic carrier, and yeah, like I could see that being a big problem.
Yeah.
And that would be interesting, right, Adam? It really wouldn't be that hard an experiment, to take a bat and put a bat in one of these hospital rooms and see what happens. But
Yeah.
I don't think that study's going to happen.
No, I don't think so either. But it would be interesting to even take a couple bats, like you said, either put them in the same room as somebody that's infected, or even just try to directly infect a bat. But the problem is, and this is sort of an ethical consideration as well. You could never release that back excuse me, release that bat back into the wild after you did that experiment. They would probably have to be euthanized. So yeah, well, thank you, Karen, for passing along that interesting new update about closing off these bat caves. Um, so yeah, so if they shine the bat signal up in the sky, there's nobody to come help. All right, sorry for my bad joke. Okay, so next little round table, we have, well, actually, so we have a new preprint article just came out, and Josh, I don't know if you saw this, but you'll find this interesting if you haven't. A lot of authors here. Oh my God, there's probably like 40 authors, 30 authors here on this. This is a from medRxiv, a preprint server, and the senior author is Albert Coe, and trying to find out where the authors hail from. It's not obvious right now where they. Nope, I can't find it really quickly, so I'm not going to spend much more time in the. Yeah, but the senior
I've
author.
noticed that on these preprints, Adam. It's hard to see where people are from on the preprints.
I know. Oh, okay. Here we go. It's like buried here. So Albert Coe, it looks like the majority of this work was done from Yale School of Medicine and School of Public Health. Okay, so Yale, and the first author is Anne Louise Wiley, and the title is "Saliva is more sensitive for SARS-CoV-2 detection in COVID-19 patients than nasopharyngeal swabs." And I looked at a little bit of the data. It seems like a pretty well thought out and performed study. And if this continues to hold, like if this data is corroborated, because this work was done in a couple hundred patients, and if this is true, which I think it will be found to be accurate, you can just see from the title, once again, saliva is more sensitive for SARS-CoV-2 detection. And if that's true, that would be a big game changer, because as we've discussed on our episodes, getting basically your very upper airway swabbed, it feels like you're getting like a brain lobotomy or something. It's very, I hear it's very uncomfortable. So if you can basically spit in a cup and detect virus via these PCR methods, that would be awesome.
That's the best news I've heard all day.
Yeah.
You're absolutely right, Adam. Patients hate that. It's not comfortable at all. And so you're right. That would be huge news. And it was good news that that those initial saliva tests came out. I think that was out of Rutgers, if I'm not mistaken.
Yeah, they had a small one, and then now there's this other one. Yeah.
And so that's really good news, because that'll be very helpful as we try to get more and more testing as we reopen. We're going to have testing available to try to sort out patients as especially as we head into flu season, where there's going to be a lot of overlap with symptoms.
Right. And I think one of the major issues with the nasal swabs is, like, it needs to be performed by a trained medical professional, and and even with a trained medical professional, I worry that perhaps every single time it's not done properly, right? Just because of chance, or the patient is squirming too much, or it doesn't go deep enough, or whatever. So
You're absolutely right, Adam. And I worry about where our numbers are because of that. If it's not
yeah,
a good sample, then it's we rely on we believe that the tests have a certain amount of reliability, right? And if it's, but that's based on everything done the right way, or at least done, maybe not done the right way, but done the same way that the
Mhm.
researchers did.
Right.
So, you worry that if you're not doing it the exact same way, you really don't know what your results are.
Yeah. Right.
And it is very difficult. You have to have the head supported, where because as soon as that hits further down into your nose, your instinct is to pull back and to get
Yeah.
that thing out. As
I
a
remember about a year and a half ago, I had a deviated septum repaired, and I went to the ENT. He did sort of like a I just want to call it like a exam of of me, and so he squirted this like vaporized like sort of like numbing agent up my nose just to do the exam, and even with that sort of temporary sort of like anesthetic, it still was very uncomfortable because he went up there with like his scope, and he was examining the area, getting a feel for what he was going to need to do, and so even with that temporary anesthetic that he shot up there, it was still uncomfortable. I can't imagine having something stuck up there, up there in some drive-through testing thing where they go up there without anything.
and then on top of that, it makes you want to sneeze too.
Oh,
And
does
so
it really? Oh, geez.
the person that's doing it, you need to be protected
Yeah,
for that procedure. Because if you're a foot away from somebody and they sneeze in your face, then if you don't have the appropriate equipment on, then you're very likely to have been exposed to whatever that person has.
great, cool. All right, so the next roundtable, we were discussing this a little bit briefly in our pre-episode chatter. Um, that so this made the rounds yesterday. USA Today, CNN, Fox News. Like I saw articles all over the place. I'm just going to read a headline here from USA Today. Coronavirus, quote, does not spread easily by touching surfaces or objects, CDC now says, but it's still, quote, maybe possible, unquote. So what do you think of that, Josh?
Um, I want to see the data. I want to see the data.
Yeah, and I tried looking at on the CDC website, and I spent maybe 10 minutes. I mean, I didn't do an exhaustive search, but it wasn't like sort of like very straightforward as to what new data they were basing that statement off of.
It's very encouraging because
Yeah.
then if you're not, then you would certainly be much less concerned going places instead of just staying at home. You would you would just have to worry about whether or not someone was in a room for an extended period of time or in a room breathing heavy, and you're going into that room before those respiratory particles hit the ground, like we've talked about before.
Hmm.
Instead of being worried about whether or not the person that opened the doorknob, for example, before you did, put something there that you could potentially put back into your system.
Right. Yeah, I'm not sure if it really changes how we approach the virus or control measures. I mean, absolutely right. It's encouraging news. I'd rather hear that than the opposite. Um, but I mean, this is true even without COVID-19. I mean, when it's flu season, um, or really anytime, you just try to get in the habit of avoiding, touching your mucous membranes like mouth, nose, eyes, with your hands, especially if you've been out in public somewhere, just try to get in the habit of, so that's going to reduce the risk of common cold, of influenza, of all kinds of things. That it's just a good practice. So you know so if just a little personal story of mine. I mean, like if I go to the gas pump, if I go to the grocery store, I mean, I mask up like I'm supposed to, all that, but I don't ever wear gloves, anything like that. Like I've never believed that touching a surface was like a major route of transmission. I would always, of course, use sanitizer, wash my hands, before touching anything. But, I think there's some good news, for people who are, very heightened and very aware of this, like they might go get groceries or, get an Amazon box delivered, and they'll, wipe the thing down with some sort of disinfectant or leave it sit for, a week before they open it. Like I think it gives a little bit of reassurance that maybe we don't have to go to those quite those measures.
That's exactly what it sounds like to me too. You would just hope that there would be a lot of data to
Yeah.
support it.
Right. I mean, in general, I mean, I'm not going to say that I, trust the CDC like implicitly, right? I mean, I always want to see the data, right? I mean, if they told me, you know, uh, to, do something that I thought sounded a little weird, I'd be like, well, can I see the data, please? But in general, I trust what the CDC says, and so there must be some reason that they're coming out with this slightly altered recommendation or news or whatever you want to call it. So.
Right, and I don't think it's huge news, right? I mean, when you see those headlines and then you go back to the recommendation, you say, well, it still
Yeah.
says that
Yeah.
possible. So
Yeah.
I
Exactly.
don't know if we need to change practices a whole lot.
And this actually is a good time to maybe interject a little bit. We had wanted to spend a little bit of time today talking about personal protective equipment or PPE. So, I did mention about gloves, and I mean, I don't wear them personally. For me, and this is my opinion, Josh, you can jump in, in a moment, but to to me, it's gloves and to some degree masks. I mean, I think they can give some people a false sense of security, but I do think that we should be wearing masks out in public. I just want to put that like straightforward. I think that there's evidence that if somebody is infected, it does prevent them from spreading it to somebody else. I do believe that from the evidence. But in terms of gloves, like for example, if I'm working in the lab and I'm working with something that is like an infectious agent that I don't want someone else to get. So once in a while in the lab, I might work with vaccinia virus, and that's um, the vaccine strain that we've used historically to vaccinate people against smallpox. Okay, so we don't have smallpox anymore, but we still use vaccinia virus in labs as like a model virus to study, virus replication, things like that. Now, for my students, they only work with mousepox, right? Because it only infects mice. It does not cause any kind of disease or pathogenesis in humans, like whatsoever. Now, vaccinia, though, it does infect humans. It can replicate in humans because, well, it's the vaccine strain. Um, and so while it's not typically or not normally disease causing, if somebody has like a skin condition like eczema or they're immunocompromised, it can potentially cause a problem. So I don't let students touch it. They don't go anywhere near it, just in once again classified under an abundance of caution type of thing. And so whenever I work with it, there's no students around, and I work in our little biological safety cabinet. Um, I do what what I'm going to do with the virus. I seal it back up, and I ethanol with let's see 70% ethanol the entire enclosure, and then I also, when I'm done with that, I turn on the UV light for about 10 minutes just to make sure that the next person that comes to use that cabinet, there's zero risk of there to be some sort of weird like carryover contamination problem. So anyway, the reason I bring that up is like when I work with that virus, I put gloves on, and then as soon as I am done working in the cabinet, before I touch any surface outside of that cabinet, I carefully take the glove off, turn it inside out, then grab I do it properly. It's hard to describe on a video, but and then I put it in the biological waste container, and now I'm free to touch other surfaces around. And so the reason I bring that up is because if, like, let's say you're at the store or you're at the gas pump or whatever, if you're wearing gloves, and if you were to do it technically according to protocol, then like as soon as you touch that gas pump and then pump, and then put gas in your car, you should take the gloves off, of course, in a proper fashion, put them in the trash, or if you're at the grocery store. In theory, every single surface you touch, you would want to take off the glove, put on a new glove, then you touch the next thing, take that glove off. So like to do it technically properly, to worry about infection spread. People just aren't going to do that. That's not practical. And so I would say just don't put the glove on at all. Because you could be contaminating surfaces with the glove in the same exact way that you would with your fingers, right? And the virus does not like eat through your skin or doesn't pass through the skin. So as long as you're not touching your face, just do what you're going to do with your regular hands, and then just use sanitizer, wash your hands before then you go about, doing other things. So that's kind of my perspective. And Josh, I'd love to hear your thoughts as well.
Well, it's funny, Adam, as you're going through your procedure, um, it's similar in the medical field. So when a doctor goes into, or a doctor or a nurse or a tech goes into an operating room, you scrub so that your hands are hopefully sterile,
Hmm.
at least sterilized as best you can. Then you go in. Um, you already have your hair covering on. You already have your mask on, your shield or goggles if that's necessary for the particular patient. And then you go in with your scrubbed hands. You push the door open with your back or your elbow, and you go in. And a person that's already sterile holds up your gown. You put your
Okay.
gown on, and then they open your gloves, so you can take your gloves out, like you said, with your procedure. So you're touching the inside part of the glove first, putting it on your hand, um, and then doing the second glove with the sterile hand.
Hmm.
Or you have someone in the operating room hold it so you can put your hands in without touching anything at all. Once you get all that, so that little inside part of the glove that you touched, you're now flipping over, so that's against either your skin or that part of the gown. And now everything is sterile, so you're allowed to touch things that need to be sterile in the operating room.
Hmm.
Um, if you make the mistake of touching something, someone in that typically an experienced nurse is going to yell at you and tell you that you're contaminated, and then you have to restart the process over or cover that area. There's very strict protocols to keep that area as sterile as possible, just like you have your protocols in your lab. And then, like you said, when you're done, then you have to take everything off, and you're careful to not, if you have anything that's on your hands, typically, um, you know, typically in that circumstance, there's going to be some blood on your hands. You're taking that off in a fashion so that you're only touching the inside part of your personal protective equipment, and you're putting it in the bin, and then you leave.
Hmm.
So you're right. That's protecting things to go from going through to get to you. If you were to touch your face, well, then you've just set yourself up. And that's one of the things we talked about with the mask before, is that I worry about people touching their face more because of the mask, because it's uncomfortable and they're not used to it. I've gotten very used to standing like this, not touching anything at all, and definitely not touching my face because I don't want to contaminate anything in an operating room. But that's something that you get. It takes a lot of experience and practice with that. And you're right. If you're touching something with your gloves on and then you touch your face, it's the same. That's the same problem. So you do worry that people are less careful, or not exactly understanding what the what the gloves are doing. I'm always, I pump gas. I get in the car. I try not to touch my steering wheel until I get my hand sanitizer on,
Hmm.
because I worry that I'm going to be lax and touch the steering wheel. Now that's what I would like to see from the CDC is how many surfaces can it touch before you have to worry about it.
Sure.
And how long can it stay on your clothes, or we have good information about how long the virus can be picked up on certain surfaces, and maybe you can
Right.
remind us on that, or update us, Adam, if you see
Yeah.
anything about the viability of the virus in those circumstances. One thing that that's always a question of how long can it. I think we talked about that a little bit, about the surfaces and how long it can last, but whether it can still infect you or not is a question.
Well, that's the unanswered question. Absolutely. So yes, I'll just jump in. That's a great lead in, Josh. And by the way, folks, we did not plan that. So by episode 7, we're sort of we're getting on a roll here. No, there was I kind of have a list here of some summaries of some recent preprints that have come out on bioRxiv and medRxiv in terms of surfaces. So they experimentally contaminated a surface of copper, cardboard, plastic, and stainless steel with SARS-CoV-2, and they found the half-life. And so experimentally, what you do is you start with like a known amount of virus. Let's just say, for example, 10,000 units. And every so often you sample that surface to see, well, how many units are left, right? And so if you start at 10,000 and so the half-life would be, how much time does it take to get down to 5,000 units, right? So, half of 10,000 to 5,000. So once you get down to 5,000 units of virus, well, how long did that take, right? And that's the half-life. And so they found 4 hours was a half-life on copper, 24 hours, excuse me, half-life on cardboard was 8 hours, and they could detect it all the way out to 24 hours. But by the time you get out to 24, there was basically trace amounts left, but still technically there. And the half-life on plastic and stainless steel was 16 hours. So like I said, that's under the most stringent experimental conditions in a lab. When you're out in the environment, I mean, I would say, especially on a surface that has sun exposure, I just know from my own experience in the lab, one of the ways you can inactivate a virus, and I mentioned this a few minutes ago, is just to shine UV light at it. It's very good at creating mutations in the nucleic acid in the genome of the organism, and that's commonly done for whether it's bacteria or viruses. It creates a lot of mutations in the genome, and it basically becomes a dead organism. And so, and Josh, great point. We still don't know what is the infectious dose, and I don't know if we're going to know that for a while. But how many units of virus does somebody have to breathe in or touch on a membrane to be, to actually cause an infection? Now, this is kind of startling, but just so people are aware, for something like tuberculosis bacterium, right? So it's called MTB, Mycobacterium tuberculosis. The infectious dose is 10 bacterium, right? That is super, super low. So you don't have to breathe in hardly anything in order to get TB. For this virus, I'm going to guess it's substantially higher than that. Viruses in general, I think, for example, influenza is around 10,000-ish plaque-forming units or units of virus for influenza. So anyway, I'm not sure about this particular virus, but I'm just going to go out on a limb here and just say, like, let's say you touch a plastic surface, half-life is 16 hours. So yeah, let's say there's a few units of virus there. My suspicion is, well, number one, you're not going to be breathing that in, like, from a surface, right? It would have to be from physical touching, then go to a membrane like your mouth or your nose, and then it's gonna. And so my suspicion is that there's not going to be enough virus there to actually cause an infection. And once again, that's just my opinion based on just what I am envisioning happening. So whereas when you're expelling virus from your airway, there can be potentially thousands or hundreds of thousands of virus particles in that cough or in that sneeze. So that's probably the major route of infection. So yeah, it's a little update on that. Okay.
Yeah, that was great, Adam. Thanks.
Yeah.
I tried to put you on the spot, and you were just right on it.
Next time. Okay, so we have two more agenda items here, and we'll wrap this up. So another little roundtable thing, a little update from the last time we recorded. This company called Moderna released some results of a phase 1 trial. And so Moderna, so what they're trying is a vaccine that uses what's called a messenger RNA or an mRNA-based vaccine. And the advantage of an mRNA-based vaccine or any nucleic acid vaccine is it's very easy. Once you know the sequence, so the A's and the T's and the C's and the G's, right, the actual nucleotide sequence, once you know that, you can very easily manufacture that piece of nucleic acid to match that sequence. So it's a relatively easy, sort of quote unquote, easier approach. So it's basically like plug and play. Like you could, if there's some brand new pandemic that started next year, brand new virus, as long as you know the sequence, you just plug it in and now you have your nucleic acid vaccine platform. And so that's why people are putting time researching it. So they released some results here. I'm just going to pull up their press release briefly. And so they evaluated this in a small group of people, and they gave 2 doses. And let's see here, the individuals in the study, all participants who were given those 2 doses, seroconverted, and that's just a fancy word meaning that they made antibodies. So they detected antibodies in those people, and the binding antibody levels were at or above levels seen in convalescent sera. So what's convalescent mean? So if somebody has COVID-19 and recovers, they now, as we discussed earlier, have antibodies to the virus, and that's the convalescent serum. So people that have survived and are making antibodies. And so this vaccine apparently in their early clinical trial elicited or induced antibody levels similar or above those levels seen in patients that actually have had the virus. So that's a very promising result. Okay. Did you have any comments, Josh?
No, that's really good news. So that's what we're hoping for. As we mentioned, there's a lot of different companies trying to get these products out, and that's the first step. Well, like we talked about, the safety is the first step, and then the next step is whether or not it produces that response in volunteers, and then we have to see whether or not it actually protects people from the disease. So
Right, right.
it is definitely a positive, a step in the right direction, but we still have a way to go.
And one of the very interesting things is, where do you do where do you do what's, so they call it the efficacy phase of, so yeah, so it's safety, dosage, and then finally, before it can be licensed, you have, well, how good is it, right? And you mentioned that, Josh. So one interesting thing here, as you know, so we definitely flattened the curve, at least in most states, and other than maybe Brazil, correct me if I'm wrong, right? And China's seeing now, it seems like an upsurge. They just closed down a different region. So I don't know if you want to call it a second wave or not, but it might be hard to try to find a population as this dies down. It might be hard to find a population of people to give the vaccine to, because you have your placebo arm that don't get it, and then you have your vaccine group. As the infections go down, it becomes harder to have a clinical trial. So that's why some people are advocating for a direct challenge study, where volunteers get the vaccine and then they get directly challenged by the virus. And I'm not advocating for that, because this can be dangerous in some people, and we still don't know what are those factors that make somebody susceptible to having that dangerous outcome. So
Yeah, there's a lot of ethical issues that you come across there, and definitely, um, I'm sure if that ever happens, those patients will be well informed about the risk that they would take, and that would be, those would be people that are really doing a tremendous public take that risk to see whether or not the medication works.
right, without the direct challenge, like you were mentioning before, and we were just talking about now, you basically have to give it to a fairly, and as the numbers go down, as the infections go down, you have to give it to even more people, right? So you have to give it to potentially, I'm just going to throw a number out there, like potentially even hundreds of thousands of people, and then you look for, well, how many of those people got infected, and hopefully the vaccine group was lower.
And if the vaccine is very effective, you don't need quite as many people.
True, true, right,
But most vaccines, aren't. It's very unlikely that the vaccine is going to be 100%.
right, right. And you don't know that going into the trial, right? Whereas if you perhaps knew that, or had an educated guess, right? If it was, say, 100% effective, then you, like you mentioned, you're absolutely correct. You'd need a lower number to start with. Yeah. And I'm not a statistician, but people call that, like, a properly powered study is the term people use. So you need enough participants to see if there's a significantly different effect between the groups. Okay, so the last email we got, and this is a comment. So this is from Ken Cleaver, Albright grad, And so I'm just going to read this. So you mentioned that you're going to discuss the PPE situation in a future episode. I hope you're going to discuss supply chains during that discussion. Um, and so Ken, just to interject, I'm certainly not an expert on that. I know that you know more about that than I do. So I didn't really know what more to add to that, but I know that you kind of touched on here in your email. So that's why I wanted to bring this up. So he goes on to say that the US economy functions much differently than other countries which have a nationalized health system. We really operate like 50 countries within a country, with states and even counties within states having to outbid other states to obtain supplies. There's no national health system in place to supply necessary equipment unilaterally to every place that needs it. The federal government does not have mechanisms in place to make that happen. What I'm trying to say is that we in the US have a very different system for purchasing goods and services, um, that has a national health system. I'm not trying to make any political statement, just the way it is, right? So Ken, so thank you for writing in again, and and for your insight. You're absolutely correct in what you say there. And so in terms of the proper equipment and supplies, it is certainly, I don't know what other than to say than you're absolutely right. And it is an interesting setup and system that we have in place here. Josh, you probably have more of an insight that than I do.
Well, no, he's absolutely right, and it is very difficult. Right now, I'm part of a group of health center directors in Pennsylvania, and we're all in the same boat. And it's sad to say, but you're almost in competition with your colleagues to try to get the equipment that you think you might need.
Yeah.
It's very difficult because I know as the director of the Gable Health Center, I want to have equipment here for my staff to make sure that they're protected. But honestly, it's more important right now that the hospitals have their equipment. So there is definitely a hierarchy of needs for a limited number of goods. So it is very difficult, and I do wish I hope that our system changes after this. There is, from my understanding, there is a national stockpile, but there was actually apparently some issues with our national stockpile. So even our reserves that way, we had some issues, from what I understand, as far as the fact that that wasn't replenished probably the way we needed it right now. So hopefully we learn a lot of very good lessons from this pandemic, and so that we're better prepared for the next one. And hopefully the next one's not for another 30 or 60 or 100 years.
Right.
It will happen again, and hopefully we're better prepared. You would think that in our country we've gotten so good at logistics that we would be a little bit better on the fly. I think I've been a little bit disappointed with the fact that we haven't been able to move things around the way that we really needed them to be moved around. I think that obviously there's major things happening with personal protective equipment, but we probably could have done less with the supplies that were available in certain areas by moving what was around nationally in a much better organized fashion.
Right. So yeah, so it's a learning experience, and I hope that we do learn from it moving forward. But if there could be some better communication between, it's almost like sort of like interagency communication of sorts, to be like, oh, well, we have this, we're in like rural Idaho, chances are we're not going to need this, so we're going to ship it off to New York City or something. And if that could be done much more streamlined and quickly, and things like that. So yeah, it's a good point. Okay, and the last thing I just wanted to mention, just to kind of round out, so just a little bit about protective equipment and disinfectants and things. I saw this was interesting. This is another bioarchive, so preprint. In terms of what kills the virus and what do we have around our house. So I'll just kind of read off some of this stuff. So there's no evidence right now that vinegar is a proper disinfectant of this particular virus. What does kill it really well is bleach, and actually bleach kills a lot of stuff. So what they recommend is a third of a cup of bleach per gallon, or 4 teaspoons of bleach in 1 quart. And that's been shown to effectively eliminate the virus, as far as I can tell. Um, One of the things that's important is contact time. And so what they recommend is, if you're going to wipe a surface, is to saturate it, right? To wipe it and then let it air dry. Don't wipe until it's dry. You basically don't want to hasten or speed up the drying process, because the contact time of the agent with the surface is what's actually doing the killing of the virus, right? So like when you do, and this leads me into ethanol, right? So ethanol or isopropanol. So those are both alcohols, but get into the weeds a little bit. Going back to my organic chemistry, we're the OH group. So there's an oxygen bonded to a hydrogen. That's called an OH group, or a hydroxyl group is another word for it. And where that's hooked onto the carbon chain makes it ethanol, which is what's in your Captain Morgan, or isopropanol, which is, you can buy that from CVS usually. Things like that. Isopropanol, I believe, is that typically referred to as rubbing alcohol, Josh? Do you know? Yeah. Okay. So yes, like rubbing alcohol is isopropanol. That you definitely don't want to drink that. Ethanol is what is in like your like your beer, wine, etc. And it's just where the OH group or the hydroxyl group is connected to the carbon chain. It changes the name, but it also changes the properties of it. But in terms of its disinfecting properties, both have been shown to be effective, and the typical concentration range would be 60 to 70%. So if, for example, if I saw a product on the shelf, say hand sanitizer, that was say 50% isopropyl, 50% ethanol, I would not buy that product. I would buy one that was closer to 60 or 70%. And why might they be different? I think it comes down to cost. I don't know for sure, but I imagine the higher the alcohol content, the more expensive it is for the company to make that product. That's my opinion. I don't know that for sure. It's so 60 to 70% ethanol and isopropanol based product, and those have shown to be effective at a 30-second exposure time in this one preprint that I saw. So once again, when you put that ethanol hand sanitizer on your hands and you rub it, you basically want to stop, like basically disperse it evenly over your hands and then stop and let it air dry on its own. And that's going to increase the contact time of the agent with the virus that might be, say, on your fingers or on your hands, things like that, or on a surface. So wipe it and then let it air dry. Okay. So the contact time for the ethanol isopropanol in this one study was 30 seconds, and the contact time for the bleach was, I think, 30 to 60 seconds. And so it's, once again, that's a third of a cup of bleach per gallon. Okay. So that's just a rundown of some of the stuff. Oh, one more thing that's interesting. So speaking of alcohol, in drinking alcohol, just a regular old, like, so I've read that people are trying to use like vodka to make, like, say, hand sanitizer. And I just want people to know that like an 80 proof vodka is only 40% alcohol, right? So that is not probably going to be high enough concentration of alcohol to really be as effective as a 60 to 70% product would be, based on the data, right? So unless you're Bacardi 151, I guess it's not going to be a high enough alcohol content in order to be a good disinfectant. Okay, so I wanted to mention that. I thought that was interesting. So Josh, did you think of anything else you wanted to add while I went through that little bit of roundtable stuff?
No, just a couple things. One, it is interesting that some of these distilleries are making, products that can be used now. So that's another part of our supply chain where where groups are stepping up to do what they can to help. I think one thing to comment about, if you have, let's say you do have a visitor that comes to your house, you're obviously social distancing. But then if you wanted to clean after that, ideally you would actually let that room sit for a couple hours if you could before you went in and cleaned. And that's that's one of the things that we're trying to get prepared for as we move forward. When we get students back on campus, we'll have our protocol, the
That's a
clean
great
rooms.
point. Yeah.
We're worried about a student potentially being infected, so that the room is safe for the next student that's going to come in.
That's a really good point. Thanks for bringing that up, especially indoors, right, Josh? Because if it is even on those small respiratory droplets, right, and that's a great point to bring up. I'm glad you brought that up. It could potentially be like circulating in the air for a little while. And so you just want to make doubly sure that gravity has pulled that all down, and you're not going to be like going and like sort of kick it up and breathe it in, right?
Right.
Yeah. So I'm glad you brought that up.
And that's part of our facilities staff it has been taking care of that stuff for us on campus here while things were going on, and that group has done a tremendous job here at Albright, and we're getting them. We're continuing to make sure that they're prepared for when we get students back here as well.
Sure, sure. And that's actually another good little sort of just a side note, like a sort of a public service announcement of sorts. There's other viruses. So for example, like if you go in like your basement or like a closet in a basement and you notice there's like mouse droppings, right? There are certain viruses like Huntington virus and different things that can be transmitted from rodent feces. And so you really shouldn't go in there and just start like sweeping up, right? Because there could be viruses that, and this is unrelated, of course, to SARS-CoV-2 specifically, but just in general, right? If you see mouse droppings, it should really be sprayed with like a mild bleach solution, let it sit, and then go in with like, say, put a mask on if you have one, then go in and like vacuum it up or sweep it up. You want to basically try to minimize kicking up dust, and then like spray it down, and then go in and clean it up. So just wanted to mention that because that came in my head from what you were saying. So okay, well, Josh, do you want to add anything else? This has been a little longer than some of our other ones, which is fine. We only did one episode this week instead of two, so makes sense that it went a little bit longer. But it's been great. Did you have anything?
Yeah, we got a lot to catch up on.
Yeah. Did you want to add anything else, Josh?
No, I think that's good. Thank you very much, Adam.
No, thank you very much. So this concludes episode number 7. And as I mentioned before, please email me with questions, as they come up, whether it's something you hear in the news or, your relative or friend says something and you're not quite sure and want to ask in a kind of a friendly environment, instead of, trying to dig through the weeds. We'll try to do that for you. All right. All right. So thank you very much and have a great day. All right. Bye, Josh.
Thank you.